Good morning, everyone. A warm welcome for all of you joining our symposium today. It happens to be a National Testosterone Awareness Day. What a coincidence that we're having our symposium today. So again, very welcome. Our body makes testosterone naturally every day, but that natural production goes down as we start aging. The modern lifestyle actually has accelerated further this age-related decline. Ironically, most of the people around the world are not so cognizant of that. As a matter of fact, there are 20 million men today just in the United States are walking around with low testosterone, and 90% of them really don't know that they have low T levels because they have never been tested or checked the T levels. What has confounded me the most since we started our clinical trial of Kaisertrax in 2010, that this awareness is so little all around the globe. What I call it low testosterone syndrome is so prevalent. And let me share a study with you. The study came out 2 years or so ago, a T4DM study, testosterone for diabetes. And it was a double-blind placebo study, and really clearly showed that diabetes goes into remission when patients are on testosterone therapy. As a matter of fact, that HbA1c level dropped by a point or more after 2 years of therapy. Now, there are over 20 million men today in the United States that are diabetic, and over 50 million are pre-diabetic. And in the US alone, we are spending over $400 billion a year on diabetes treatment care. Now, imagine a situation where this 50 million plus men pre-diabetics turn diabetic, how much money the system is going to be spending. Now, imagine a scenario where a lot of these men that do have low testosterone get on an adequate testosterone therapy and the savings to the system. Before I turn the call to our speaker and moderator, Dr. Morgentaler, I just want to say a little bit about him. He pioneered the modern use of testosterone therapy in men. And also his landmark research revolutionized the understanding of the relationship of testosterone and prostate cancer. I have had the pleasure to have known him for a number of years. Abe?
It amazes me. I've been doing this, as you'll see, I've been doing the work with testosterone for more than 40 years, which really dates me. It's amazing to still be doing this. And part of what has motivated me over the years is just that to some extent, there has been this resistance to it. Let's go forward. So we have this paradox. And in essence, this is really why we're here today. And here's the paradox. We have the highest level evidence that can exist that testosterone therapy has important beneficial effects for some of the most critical healthcare issues that affect men and to some extent women in this country and around the world. You're going to hear talks today on obesity, on diabetes, on COVID, and there are a number of other important areas too that you won't hear anything about today just because we don't have time. For instance, osteoporosis, anemia, and even depression. Excellent data. Yet somehow within medicine, all these benefits around testosterone have gone almost completely unrecognized. Our next speaker is Dr. Traish, Abdul Traish. Abdul is a dear friend of mine. We've written so many papers together. He is Professor Emeritus of Urology and Biochemistry at Boston University Medical School. He's Editor-in-Chief of the medical journal Androgens, Clinical Research and Therapeutics. And Abdul has authored some of the most seminal works in testosterone research in animal studies and also in human clinical studies. Abdul, you're on.
Thank you, Dr. Morgentaler, for this very generous introduction. And I would like to begin by thanking Marius Pharmaceutical for inviting me to participate in this provocative discussion. As you can see from the title of my presentation, it is going to be a very provocative discussion. I just want to highlight this, which is very important. This is published in Mayo Clinical Proceedings. This is the results from a discussion of an international expert panel. This is people who spend their careers studying testosterone deficiency, testosterone therapy. And what this panel came with 9 resolutions. And the 2 that I thought are very critical is that testosterone deficiency has a detrimental impact on human health. I want to repeat, testosterone deficiency has a detrimental impact on human health, and it's well documented and well demonstrated. The other resolution that this panel came with is that symptoms and signs of testosterone deficiency occur as a result of low testosterone, and men may benefit from treatment regardless whether they're young, they're old, they have obesity, they have diabetes. Irrespective of the etiology, men may benefit from this. These are really important resolutions based on this panel discussion. I think this is another critical piece of data which is present in the literature in many forms, which is low testosterone is associated with the increased mortality. Testosterone therapy reduces mortality by half. And this is in systematic reviews and meta-analysis. This is in clinical studies. The data come together suggesting that testosterone therapy reduces mortality by almost half.
We're going to move on. Our next speaker is Mohit Khera. He's professor of urology at Baylor College of Medicine in Houston. And Mo, you're up next.
One of the studies that we published in 2013 was giving men testosterone who were at high risk of developing prostate cancer, meaning high Gleason scores, positive surgical margins, positive lymph nodes. In our study, we looked and we found that those men who received testosterone actually had a lower risk of recurrence of their prostate cancer than those men who did not receive testosterone. And that recurrence rate was quite low. It was only 15%. And many have asked, in any way, could this be protective against the recurrence of prostate cancer because your recurrence rates are too low? Well, after this study, there were several other studies also looking at testosterone and prostate cancer. This was by Stacy Loeb in 2017, where she looked at a national registry study of almost 1,400 patients, controls, and almost 300 patients who had prostate cancer. And what they found was that there was no association between testosterone and prostate cancer, but patients who received testosterone had a low risk of aggressive prostate cancer, which was interesting. So in conclusion, there is currently no evidence that testosterone therapy promotes the initiation of prostate cancer in hypogonadal men. Testosterone therapy is now being used in clinical trials to treat men with metastatic prostate cancer. There may be a therapeutic and/or protective role of testosterone therapy against prostate cancer.
Paresh Dandona is Professor Emeritus of Endocrinology and Metabolism at the State University of New York in Buffalo. He's been an absolutely critical player in describing the relationship of testosterone deficiency and also the effects of testosterone therapy in diabetic men. The area of diabetes and testosterone, in my opinion, is one of the most important broad strokes issue in healthcare and certainly around testosterone therapy. So it's my delight to introduce Paresh Dandona.
Now, when we give testosterone to these patients over a period of 6 months, this was the study that we did, you can see that the testosterone concentrations were steadily increased during this period, whereas the testosterone concentrations in the placebo group that was not treated were unchanged. Next slide. And then the other interesting thing is that during this 6-month period, the total lean body mass, i.e. the muscle mass, increased significantly, while the total fat mass diminished. And this is very important. And this is one of the things that one has to emphasize when we talk about overall quality of life and so on, that the muscle mass is dependent upon testosterone and increases under the influence of testosterone, whereas adipose tissue, fatty tissue, diminishes. And this issue will be discussed later on by Farid Saad when he talks about the long-term effects of testosterone. So then we go on to the T4DM study from Australia. And this was also mentioned in the passing by Dr. Traish, but I just want to mention here that these were patients either with pre-diabetes or with early type 2 diabetes. And when they were given testosterone therapy along with lifestyle program changes, they had some very interesting effects. Next slide. And you had a decrease in the outcome measures with prevalence of type 2 diabetes in these early type 2 diabetics, coming down by more than 41% in comparison with the placebo arm. So clearly it has an anti-diabetic effect. So let me then conclude by saying that the hypogonadal state is a part, almost an integral part of having type 2 diabetes and being obese. You need to measure testosterone in every one of those patients. And then testosterone administration reverses the extra insulin resistance that these patients have, and that can reflect in reversal of diabetes and pre-diabetes.
So our next talk is by Farid Saad. In addition, as an investigator, Farid has been involved in a number of very important studies, especially in what he's going to be speaking about today, which we have relatively little information on the long-term effects of testosterone therapy. And Farid has been part of a research team that has been looking at this, and it is my pleasure to introduce Farid Saad.
We established with very good friends of mine who run a urology office in the north of Germany. We established a so-called registry study. This is an observational study which just looks at patients as they come in. Patients are routinely screened for their testosterone levels. Those who have low testosterone are offered testosterone therapy. Some patients accept it, some patients don't. So this is not a randomized controlled trial. This is a real-world evidence trial. And this is the baseline characteristics. Meanwhile, the study that was started in 2004, 2005 has almost 900 patients with low testosterone in the study. They're all treated by the same urologists in Germany. This is a subgroup analysis of those patients who had type 2 diabetes. And it's interesting to note that of the total population that are in this study, we have more than 41% who have diabetes, which underlines again the high prevalence of low testosterone in men with diabetes. So this subgroup has 190 men with diabetes who receive testosterone, 180 who don't receive testosterone because they opted against testosterone treatment, and they served as a control group. Mean age was around 60, testosterone was low, BMI as a measure of obesity was high, so the majority of these patients were indeed quite obese, and the HbA1c as the most important parameter, the most important clinical parameter in diabetes, which reflects the long-term blood sugar control, was high in these patients. It's important to note that all these patients receive standard treatment at the local diabetes center, which includes mandatory lifestyle modification courses. So they get educated about nutrition, about exercise, and this is something they have to attend. And of course, the urologist does not treat diabetes. These men come to the urologist because they have erectile dysfunction, they have urinary function problems, or they want to undergo their regular prostate checks. So when we look at the results from this, we are now able to analyze 13 years of follow-up in these patients. These are testosterone levels. You see the green line is the group receiving testosterone. Testosterone normalizes after the first injection. We use injections. This is the threshold, the red one, which was already named which is widely accepted in Europe, but also in other parts of the world, 12 nanomol per liter. So in these patients, testosterone normalized. This is the control group. And in the control patients, testosterone further declined with advancing age. Now, when we look at weight change, this is something that first came as a complete surprise to us because it had never been published from any randomized controlled trials, but we saw a progressive weight decrease in the testosterone-treated group over the years. At the end of this 13-year observation time, patients had lost, on average, 22% of their weight, whereas in the control group, shown in green, there's a slight but steady increase of weight. So this takes time, and you can see here, after 1 year, the weight loss was just about 2.5%. This is certainly not a weight loss that anybody would get excited about, especially in these grossly obese patients with type 2 diabetes. This is HbA1c, the measure of blood glucose, of blood sugar control. And you see here the steady improvement, the drop of HbA1c in the patients receiving testosterone. Here's again another threshold drawn in. This is the threshold for diabetes. Everybody who has an HbA1c of 6.5% or more has by definition type 2 diabetes. And there was an increase, a worsening of the condition in patients who did not receive testosterone. So in conclusion, long-term testosterone therapy results in profound weight loss maintained over up to 13 years. Untreated hypogonadal patients gain weight. Long-term testosterone therapy results in marked improvement of type 2 diabetes. More than 50% of patients may achieve remission of diabetes, which can otherwise only be achieved by bariatric surgery. So massive weight loss following, for instance, gastric bypass surgery. Untreated hypogonadal patients' diabetes progressively deteriorates. Long-term testosterone therapy results in reduced mortality, myocardial infarctions, and strokes. These findings were initially unexpected and may only be achievable with long-term, lifelong testosterone therapy. Thank you very much for your kind attention.
Our next speaker is Dr. Barua. Dr. Barua is the Chief of Interventional Cardiology at the Kansas City VA Medical Center, Director of Cardiovascular Research at that same institution, and Professor of Medicine in the Division of Cardiology at the University of Kansas School of Medicine. Very much looking forward to this, Dr. Barua.
So we looked at our VA database, all comers. There's 200 plus VA medical center in this continental US. We looked all of the patients who were getting testosterone therapies and who had first got testosterone measurement, who at least had 2 measurements of testosterone. Then we divided it into 3 groups. One, they did not receive any testosterone, although they were lower after 2 measurements. One, they got treatment, but did not go to the normal level. And another group was level 2 level drawn, decreased testosterone, and they were adequately treated. I think this is our study was a more comprehensive look at the normalization of testosterone. This group of populations did not have any previous MI, stroke in this population because we wanted to see patient with general risk, not a high cardiac risk. So on that population, we found, to my surprise, actually, I went with a bias, although I had these doubts that that testosterone therapy may be more harmful than good. To my surprise, we found we actually really propensity matched them. It's a rigorous statistical exercise we have done to make sure we got this right. We found, to my surprise, that patients without previous MI and stroke, if you normalize testosterone, it decreased MI, stroke, and all-cause mortality. And it is also highlighted that if you didn't normalize, you still had a higher event. So normalization of testosterone, what you're hearing, this is really highlighted by our group, that if you treat them effectively, you will have an all-cause mortality decrease, you'll have MI decrease, as well as stroke decrease. This is 83,000 patients over 15 years of follow-up. Median follow-up is about 5+ years. So in conclusion, low testosterone associated with increased mortality or CV events. In patients with prior MI, without prior MI and stroke, normalization is associated with decreased mortality, MI, and risk. Smoking decreases some of this beneficial effect. Even in previous MI, patients with normalization of low testosterone associated decreased mortality and not associated with higher event. So thank you.
Our last speaker is on our panel is Sandeep Dhindsa, who's Division Director in Endocrinology at St. Louis University. Dr. Dhindsa published recently an article on testosterone therapy and severe COVID that I thought was really important. And thankfully, severe COVID rates are relatively low now, but it hasn't gone. And I think this is a very important article and presentation. And so it's a pleasure to introduce Sandeep Dhindsa.
We conducted this study, association of male hypogonadism with risk of hospitalization from COVID-19. It was published a couple of months ago. And this was a retrospective cohort study. We did that in 2 large academic health centers in St. Louis. We reviewed the charts of men who had a history of COVID-19. Some of them got admitted, some of them had milder course and did not get admitted. And we selected only those men who had at least one testosterone level checked in the last few years. And these testosterone levels were done when they were healthy, did not have COVID. It was not a testosterone level while they were sick from COVID. And our goal was to compare the COVID-19 hospitalization rates among 3 groups of men. Eugonadal men, meaning those who have normal testosterone, or hypogonadal men, meaning those who had low testosterone but were never treated. And then the third group is those who were getting testosterone therapy. And we made sure that we did statistical adjustments for differences in the risk factors for COVID severity. Everyone knows that if you're older, you are going to have more chances of getting hospitalized from COVID or having a severe outcome. And similarly, obesity, immunosuppression, all other comorbidities, race, etc. And this is the total number of men in the study, 723 men. Out of these, 180 were on therapy, and the rest were not on therapy. 116 were low testosterone, and 427 were hypogonadal. So let's see what their baseline characteristics were. So those who were hypogonadal, as expected, were older because aging causes lower testosterone. So they were older than the other groups. They did have more comorbidities, such as diabetes and cardiovascular disease. The numbers in parentheses are all percentages, so 21% versus 11% in the hypogonadal and eugonadal group. And then 16% were immunosuppressed. But what really startled us was that 45% of these hypogonadal men ended up getting admitted if they had COVID, as compared to only 12% in the eugonadal group and 16% in the testosterone therapy group. So overall, what this basically means is that hypogonadal men are around twice more likely to get admitted from COVID, even after we have adjusted for everything else that we can think of would be a contributing factor towards COVID. And at the same time, those who are getting treated with testosterone do not have an increased risk of getting admitted from COVID. So I'll summarize by saying that low testosterone is not protective against COVID-19. On the contrary, it's a risk factor for COVID-19 severity. Hypogonadal men are twice more likely to be hospitalized after COVID as compared to eugonadal men, independent of other known risk factors. This increased risk was not observed among men receiving adequate testosterone therapy. And we need to think about screening and treating hypogonadal men appropriately as a strategy to prevent severe COVID outcomes among men. So thank you very much for your attention.
Actually, Farid, I think you've been involved with some work with testosterone and inflammation. What can you tell me about the use, what can you tell the audience about the effects of testosterone therapy and other inflammatory type conditions?
Yes, this is something that I was always fascinated with. There are several small studies that show that testosterone lower C-reactive protein, which is a very popular, or let's say often measured inflammatory marker. There are also studies showing the suppression of the production of TNF-alpha, the tumor necrosis factor alpha, which plays a major role in autoimmune diseases. And we had the opportunity to have in our large registry study more than 70 patients with Crohn's disease, which is an inflammatory bowel disease, an autoimmune disease. And we found, by more or less coincidentally, that these people responded very, very well to testosterone. So here we see the basic research that shows that testosterone suppresses TNF-alpha. We see this translated into the clinical setting, and patients with Crohn's disease within 2 years had such a dramatic improvement of their Crohn's disease that we couldn't believe it. We published it. Nobody seemed to be interested. And we also have to see this in the context that the largest selling drug at this age is a drug that suppresses or that counteracts TNF-alpha. It's a drug called Humira. And we know that testosterone more or less does the same by different mechanisms. But this is something where we also need to take into consideration the power of companies that have such huge selling drugs, and they more or less seem to have at least a major impact on what's going to be presented at a gastroenterological conference and so on and so forth. So I think that money is also a major driver of why testosterone doesn't receive the kind of acknowledgement that it deserves.
Thank you. Mo, our sponsor today has come up and recently had approved an oral testosterone product. One of the nice features about it is that testosterone levels don't go excessively high, certainly in comparison to the most common form of testosterone used in the States, which are these short-acting injections. And changes in hematocrit were pretty unusual in them. And that hematocrit, a rise in hematocrit for some of you in the audience, is a rise in your red blood cell count. And many individuals, as doctors, as Dr. Barua was saying, one of the concerns about testosterone is the potential for thrombosis or clots, and higher red blood cell counts are thought to contribute to that. Mo, there have been other oral testosterone products. They've been very expensive. There have been insurance issues with them. But what do you think about the potential for an oral testosterone product in the United States and its impact on health, given that the levels don't go up so much, as long as, of course, and assume that the product will be affordable and relatively easily obtainable?
Sure, Abe, oral testosterone has been around since the 1970s, oral testosterone decanoate throughout the world. It just didn't come to the United States till 2019. But if you ask patients and you give them surveys, most patients like to take an oral medication. They're used to it. It's simple. It's non-invasive. It doesn't involve a needle. And they also feel there's no risk for transference. Transference means if you put a gel on your shoulder, if a baby touches that gel or a pregnant woman, there's a risk. With the oral, you don't have that risk. So I think that, Americans will like to take oral medications. There's less chance for abuse or supraphysiologic levels, so you can't inject more. So for many reasons, the orals seem to be very favorable. And I think the orals are an excellent medication. One of the concerns we had many years ago was that orals would cause liver damage, but that doesn't happen with testosterone decanoate. There's no concern for liver injury. So again, they're safe and they're effective, and I think they're very simple to use.
Thank you so much. Abdul, let me get you up on my screen. You've been involved in research with this for a long time. And, what strikes me about testosterone therapy, and as exemplified by the variety of topics that were covered here just today, is that it plays a role in so many different body functions, if you will, so many organ systems. Its deficiency has such wide-ranging properties. The presence of a low testosterone appears to be predictive of developing certain problems, bone issues, more increased mortality. The argument has come up that maybe testosterone is the single best biomarker we have for health, and that today blood test for testosterone is generally not done on routine doctor's office visits. And my question to you is, should it be? In your opinion, and what do you think of the possibility that I just said, that maybe testosterone is the single best biomarker of health that exists?
Well, to give you my opinion first, is that testosterone is an important natural hormone that the body has a manufacturing gland called testis to make for over our entire life to maintain our health and our physiological function. To answer the second question, Dr. Bu Yeet from Australia have reported in a very nice article that testosterone may be an indication for good health and low testosterone is an indication for poor health. However, this has not seemed to permeate the clinical community at large. So I agree 100%, testosterone may be a single important marker for men's health. And low testosterone may be a really, really serious risk factor for all aspects, whether it's diabetes, obesity, kidney function, liver function, cognitive function, sexual function, etc. So I actually am a proponent of the argument that testosterone is really an important marker for men's health.
Well, our time for this panel has ended. I want to thank all of you for participating. We have one more thing to do, which I'd like to turn this over to Shalin Shah, CEO of Marius Pharmaceuticals. Shalin?
Thank you, Abe, and do appreciate you fostering a very direct and candid conversation covering the importance of testosterone here today. Again, do want to thank all the speakers for their deep work in this field, which we've clearly shown today, again, that has the potential to benefit so many patients. It's truly amazing to hear all these different aspects of health in which testosterone plays a critical role, whether that's cardioprotective, diabetic factors such as A1C and insulin resistance, and also inflammation, which is the root of so much disease. It's interesting, you add all this up and we get a decrease in all-cause mortality by 50% with adequate testosterone therapy. And it's simply shocking that this is not front and center in a society that has become so health conscious. Marius sees the future of adequate testosterone therapy being synonymous with preventive healthcare, and this will be a key tool in reducing the burden of exploding healthcare costs. I do hope the U.S. Prevention Task Force did indeed join the symposium today. We also hope all our listeners have truly learned during today's session, and you share this message with friends, family, colleagues, and join us on the mission of improving millions of lives. Thank you.